Thanks, Dr. Gleave. So I'm Mark Dawidek, for those who I haven't met yet. I'm a fourth year resident here, and I'll be leading this discussion around salvaging prostate cancer local recurrences, predominantly after initial radiation therapy. So as a general overview, we'll be reviewing the definitions and workup around PSA recurrences after radiation therapy, examine the factors to take into consideration when deciding whether to intervene, and compare and contrast the salvage interventions available. Radiation therapy is, of course, a standard of care option for intermediate and high-risk prostate cancer. There's evidence of equivalent oncologic outcomes with surgery with radical prostatectomy, though there is a bit of a different side effect profile. It encompasses external beam radiation therapy, which in the modern era is delivered primarily in an intensity modulated technique with conventional doses of about 78 gray and 39 fractions, or hypofractionated doses of 60 gray and 20, and concomitant administration of androgen deprivation, typically 6 months in intermediate risk and 18 to 36 months in high risk. It also encompasses brachytherapy, either monotherapy, usually reserved for intermediate risk disease, or as a boost in conjunction with external beam therapy. And this is delivered via low dose rate or permanent seeds, or high dose rate temporary implant techniques. So looking at some of the major databases, we see that approximately 1/3 to 1/2 of patients are treated with radiation for their prostate cancer. The top there is from the NCDB, the SEER data on the left there, and then some Canadian data from Ontario, actually suggesting that there's an increasing use of radiation over the years, though there's decreasing use of brachy monotherapy. As with primary surgery, we follow PSA to detect recurrences following radiation. PSA remains the most sensitive and most validated biomarker for prostate cancer recurrence. However, because the prostate remains in situ, post-radiation PSA kinetics are more complicated to interpret than the binary undetectable versus detectable paradigm we see following surgery. PSA will usually reach a nadir within 1 to 3 years, but benign elements of the prostate continue to produce PSA, and they're subject to the fluctuations of infection, sexual activity, etc. There's also a well-recognized bounce phenomenon with a small transient PSA increase, which typically subsequently drops quite rapidly. So the current definition for biochemical recurrence following radiation is the so-called Phoenix criteria of simply a PSA increase of greater than 2 above the nadir, which was established in 2006. This was changed from the previous definition, or referred to as the Astro criteria, which was 3 consecutive increases above nadir. And this was designed to focus and favor specificity for clinical failure. So it's superior at predicting outcomes such as metastases-free survival and cancer-specific survival. But as we'll see, this can limit its use clinically in the salvage setting. So what are the recurrence rates? So this is a large retrospective cohort from MSK, this Zoomsteg trial cohort. It's one of several such published cohorts from many of the large centers, and generally describing a similar natural history. Here we see an 8-year biochemical recurrence-free survival, ranging from 57 to 77%, depending on the risk group, between intermediate and high. And since we're examining local salvage, in their cohort, they saw isolated recurrence rate was 8 to 12% at 8 years. So about 40% of patients develop biochemical recurrence, and about 10% develop clinically detectable isolated local recurrence, at least by conventional evaluation. So traditionally, biochemical recurrence established an occult disease state. So with a limited ability to exclude distant recurrences. This is because conventional imaging has low sensitivity at lower PSA levels. So we see that bone scan is positive in only approximately 5% of patients with a PSA less than 10. And CT scan is rarely positive in patients with a PSA less than 10, and takes a number of years to see anything on imaging following biochemical recurrence. Confirming a local recurrence has been somewhat more feasible than excluding a distant recurrence. While the PIRADS guidelines for prostate multiparametric MRI do not apply post-radiation because the prostate gland fibroses and it becomes quite atrophied. The zonal anatomy is quite indistinct and there's just diffuse low signal intensity on T2. The recurrent, the prostate cancer recurrences do tend to enhance nicely though with contrast, as we see on the DCE phase images on the right compared with the T2 images on the left. So multiparametric MRI has a role, and it's particularly useful for directing biopsies, as 20% of biopsies in the local, in the post-radiation setting will miss detecting a cancer. So while biopsy is not usually recommended with suspicion of local recurrence following radical prostatectomy, it's usually recommended following radiation. An important point to consider is the timing of the biopsy. The DNA damage mechanisms through which radiation therapy functions are not instantaneous. So early biopsy is challenging to interpret, and positive malignant cells do not necessarily equate to treatment failure in the first 6 months to a year following radiation therapy. And previous studies recommend waiting for at least 18 to 24 months before biopsying to get a more conclusive result. So we're undergoing a bit of a paradigm shift with respect to staging, really because of PSMA-PET imaging. Traditionally, we've had a period of occult disease with lesions likely present, but we're not really sure what's going on, where they are. And this is really kind of further divided into two windows. There's in the radiation setting, at least, there's the sort of nadir to meeting the formal definition of biochemical recurrence window, which is quite a wide window with the Phoenix definition, because it is designed to be specific for clinical failure. And then there's the kind of biochemical recurrence to the time where we can detect recurrences on conventional imaging window, which can be even wider. So PSMA is a prostate transmembrane protein whose expression increases with increasing cellular dysplasia, and radiolabeled antibodies or molecules binding PSMA have markedly increased sensitivity and specificity for localizing small volumes of disease at low PSA levels, or essentially turning occult disease into overt disease. So previous reviews of PSMA looked at both primary and secondary staging together, but PSA level can have markedly different meanings in these disease states. So this recent review published in European Urology from Pereira et al. Specifically examined PSMA-PET performance in the context of low volume advanced disease, essentially biochemical recurrence. And the detection rates shown here are actually from mixed data with both post-prostatectomy and post-radiation patients, as there weren't enough studies to specifically look at radiation and PSA levels alone. What's interesting to me is that patients meeting the Phoenix criteria, who will by definition have a PSA of at least 2, 95 of them are expected to be PSMA positive, which of course is in line with the intention of the Phoenix criteria definition. They also looked at the distribution of recurrence sites, and on meta-analysis found that 52% of post-radiation patients had local recurrence. And this is either isolated or in conjunction with other distant recurrences as well. And they examined this separately for this. They were able to examine separately for both the surgery and radiation patients. And what was interesting is that there was quite a marked difference in local recurrence patterns between the two. While radiation saw 52% of patients with signal in local recurrence, there was only 22% seen on meta-analysis for the prostate, for the surgery patients. And these are 2 retrospective studies looking specifically at PSMA-PET in patients in that window between nadir and meeting Phoenix criteria for biochemical recurrence. Both of these studies included about 300 patients. The top study is from Australia and the bottom one is from the Netherlands. And they had similar findings with approximately 1/3 of post-radiation patients with rising PSA who did not meet the Phoenix criteria, demonstrating isolated local recurrence. And this was with an interval, I didn't note it here, of I think 90 months in the top study and 70 months in the bottom study. Interval between treatment and actually getting the PSMA. So this wasn't early imaging or anything like that.
So Mark, just to clarify, this is 30% of patients have evidence of residual disease, all comers, or is this only in those with rising PSAs?
This is rising PSA. Rising PSA, but in that window between nadir and reaching the kind of Phoenix criteria of PSA plus or nadir plus 2. Okay. So in that narrow window, 30% had evidence of just isolated local recurrence. The actual overall positivity was 75 and 84% respectively. And so what's more, and we won't really delve into this as much, it's sort of outside of the scope of this talk, but PSA, based off some of these studies, PSMA seems to be able to discriminate other low volume advanced disease states as well, including isolated regional lymph node recurrences and oligometastatic recurrences. It certainly raises the question of metastasis-directed therapy, which is a different presentation perhaps in itself from local salvage, but there have been a handful of phase 1 and 2 trials in this disease space with some promising results highlighted here and some still pending. So how have we been managing patients with local recurrence after primary therapy? Well, it seems the combination of PSA levels, which are more challenging to interpret, conventional tests with low confidence of ruling out disseminated disease, and overall impression of severe morbidity with our curative intent salvage options. It seems they've discouraged curative intent salvage in this context. And there's evidence to suggest perhaps undertreatment. The CAPTURE is a longitudinal multi-center study through UCSF. They found that 68% of patients with biochemical recurrence received ADT, while only 4% 4.4% received curative treatment. We actually looked at this at UBC a number of years ago. It was, I think, Dr. Tran, while he was still a resident, with Dr. Black, reviewed some of our data and found fairly similar results. 72% ended up on ADT, not necessarily up front, but about half of those, or 2/3 of those were started on ADT up front. The other third eventually ended up on ADT, and just under 2% received curative intent treatment. So there's no good evidence out there for a benefit to treatment in the post-radiation setting, in the sense that essentially all the trials studying any sort of curative intent salvage are single-armed small trials. It is better studied in the post-prostatectomy setting, where there are a number of trials which directly compare salvage versus hormonal or no therapy whatsoever, which certainly demonstrates some benefits. So to a degree, we have to extrapolate from those findings. And it becomes a question also of when to intervene. This is, again, data from the MSK group on the natural history of progression following biochemical recurrence. And they saw a median time to distant metastases of 5.4 years and a median time to prostate cancer mortality of 10.5 years. So in general, as is often the case with prostate cancer, progression is slow. And as a starting point, it's important to take into account the patient's life expectancy. Are there other prognostic factors which can help us determine which patients with a rising PSA or biochemical recurrence following radiation might progress to metastases or prostate cancer mortality? Again, this is from that MSK cohort, but this has been demonstrated in a number of different cohorts as well. PSA doubling time is the strongest and most consistently reported prognostic factor. And then the interval to biochemical failure, which is a related, in a way, temporally related parameter, is also the most strongly associated, or is also very strongly associated. The initial Gleason score and initial stage are unsurprisingly other factors that came out in a number of the studies. So there's a recent large systematic review from a group in the Netherlands looking at all of these studies, both in the post-prostatectomy and in the post-radiation setting, to try and determine the prognostic value of biochemical recurrence. And unsurprisingly, they found that biochemical recurrence was an independent risk factor for distal metastases and prostate cancer specific mortality. What was interesting is that they found it was less strongly associated with overall mortality, which suggests that there's subgroups of patients who benefit from androgen or from salvage treatments versus other patients who might be better off managed conservatively. So in their meta-analysis for radiation specifically, interval to biochemical failure, as in the previous individual studies, came out as the strongest prognostic factor. And as I had sort of alluded to, this is effectively unifies PSA nadir and doubling time into a single parameter. Either a high nadir or a short doubling time, or both, will drive a short interval to biochemical failure. The other factor that they consistently saw was biopsy Gleason score, and that's post radiation biopsy. So this was formulated into the European Association of Urology Biochemical Recurrence Guidelines, and incorporated into their prostate cancer guidelines in general. And so they address biochemical recurrence both after radical prostatectomy and after radiation, with slightly different definitions of low risk versus high risk biochemical recurrence. After radiation, they said interval to less than versus greater than 18 months, and biopsy Gleason 8 to or greater than 8 or less than 8 were the dividing points between high and low. This was validated in a prostatectomy cohort, but has not really been validated in a radiation cohort yet. One thing they didn't specifically address, or we haven't really talked about to this point, is what is the optimal timing for salvage? And again, it has not been as clearly looked at in the radiation setting, but it has been looked at more so in the post-prostatectomy setting, where it's thought that the lower the PSA, the more likely salvage is to be successful, with a commonly accepted threshold of less than 0.5, which is nicely illustrated in these figures here. So essentially, if we extrapolate this to the post-radiation setting, waiting for the Phoenix criteria is likely suboptimal in terms of considering timing for local salvage radiation. So we'll move into chatting just what our options for salvage are a little bit, broadly divided into, our options in general are broadly divided into non-curative and curative. Watchful waiting, of course, is reasonable in a patient with older with comorbidities or in that lower risk group. And we'll look at androgen deprivation as well as a non-curative option, and then all the curative options here as well. There's not a lot of evidence looking at androgen deprivation versus curative intent treatments, certainly not in the radiation salvage setting. There is one randomized trial in the post-prostatectomy setting looking at salvage radiation versus androgen from a group in Japan, published in European Urology in 2020, which suggests that curative or definitive salvage was superior to androgen deprivation as a salvage treatment. So looking at androgen deprivation, there are a couple questions to consider. And part of this overlaps with what George chatted about last week in his talk on intermittent androgen deprivation therapy. So this is the TOAD trial, which is a phase 3 randomized trial looking at rising PSA. They recruited both patients who had curable and non-curable disease, but a majority of them were post-primary therapy, essentially biochemical recurrence patients. Sort of 260 out of 290 patients fell into that category, and most were actually radiation patients. And the results favor immediate androgen deprivation therapy initiation following biochemical recurrence rather than delayed. And they defined delayed as at least 2 years or until there was other clinical factors which might push you to initiate androgen deprivation, like accelerating doubling time or symptoms. But interestingly, when they looked at this, a lot of this benefit can actually come from prostate cancer specific survival. And also, you don't really see the curve separate until about 5 years, at which point they had quite low numbers. So the confidence interval is quite broad, 0.3 to 1.12 for their hazard ratio of 0.58. They found, interestingly, that there was a comparable quality of life between the delayed versus immediate initiation of androgen deprivation, with 2/3 likely attributable to the fact that 2/3 of the immediate start patients were started on intermittent androgen deprivation. And then this data was combined with data from the ELAT trial, which is a Canadian trial, which failed to accrue. And interestingly, when the two trials were combined, there was no difference in overall survival between the two approaches. The other question, of course, is the ADT schedule. I won't go into great depth about this. This is the trial from Crook, Dr. Crook, in 2012 that George looked at a little more extensively last week, basically saying that intermittent androgen deprivation was non-inferior in terms of overall survival versus continuous ADT, and that patients on intermittent ended up having about 2/3 the duration on ADT compared to continuous. So in summary, there's no standard of care consensus at this point, but ADT can be considered in patients with adverse risk factors such as a rapid PSA doubling time of about 6 to 12 months, or more aggressive disease in terms of Gleason scoring. One other question that comes up that there hasn't been studied yet, but there are ongoing styles. The Embark trial looks at androgen receptor axis therapies. So they're specifically looking at enzalutamide in high-risk, non-metastatic, castrate-sensitive prostate cancer patients with a rapid PSA doubling time. They're looking at this post-radiation and radical prostatectomy. They're planning to randomize about 1,000 patients to these three arms, and in an intermittent sort of fashion, where if they reach PSA undetectable, they will be taken off the treatment and then reinstated if the PSA reaches certain thresholds again, looking at a primary endpoint of metastasis-free survival. So that will be forthcoming, I think, in at least, I think it's suggested 2026, so it's a bit of a ways off. So now getting into sort of the classic salvage curative intent salvage options. Prostatectomy is probably the most established option, the most longstanding option. It's obviously a challenging procedure post-radiation, which has historically been quite morbid, though outcomes have been improving with time, and that's likely a factor of better patient selection. And both open and robotic approaches are appropriate. I think what's important is that it's reserved for high volume tertiary centers with experience treating advanced and post-radiation disease. So from an oncologic perspective, this CHADE series from 2011 is a multi-center study, the largest cohort reported on. I think we at UBC actually contributed patients to this cohort as well. It dated back all the way to 1985, and they found 5-year and 10. They had sufficient follow-up to look at 5-year and 10-year outcomes with the recurrence-free survival or biochemical recurrence-free survival and cancer-specific survival reported there. This MARA trial is probably the most recent, or not trial, sorry, cohort is the most recently reported upon cohort. It's from predominantly Australia and Italy, and it's not actually exclusively in post-radiation patients. They actually had about 2/3 post-radiation patients and 1/3 post ablative therapies like focal and cryo salvage. And they had similar, at least so far, oncologic outcomes. And then this bottom one here listed is the CHADE. It's a systematic review that was published in 2012, which had quite a broad range of outcomes. And this is likely a factor of, multiple or many numerous small trials from smaller centers, and a very long time period over which they were reviewing these results. So one thing that came out of all of these is that the strongest predictive factor, analogous to post radical prostatectomy salvage, actually was the pre-salvage PSA, as well as the biopsy Gleason score. So the perhaps aversion towards salvage radical prostatectomy has historically been the fear of complications and fear of poor functional outcomes. So the Gatto study here is a large series from MSK, one of the larger series specifically looking at outcomes. Unfortunately, that CHADE study didn't report on outcomes so much as just oncologic outcomes. And the Gontero study is the companion study to this MARA study, looking at functional outcomes, with the caveat that 1/3 of these patients had post-ablative therapy salvage. And what we do see is that, in general, outcomes have been, or in terms of complication and function, have been improving over time. The most sort of feared outcomes historically have been rectal injury, rectal fistula, and we see that these tend to be on the decline. Historically, rates of up to 10%, now near under 2%. The one sort of persistent, I think, challenge is with anastomotic stricture in terms of complications, with rates as high as 40% of bladder neck contractures. From a functional perspective, essentially all of these patients have very poor erectile function by the time it comes to any sort of salvage treatment at baseline from their initial treatment. So erectile function across all salvage modalities is very rarely spared. The big one that is considered is often continence. And there's very broad ranges of continence reported in the literature. I think it's because there's a lot of inconsistent definitions. Some people reporting no pads as continent, 0 to 1 pads. So various definitions of continence. But in Gatto's group there, they had 30%, that's complete continence, so 0 pads. And in this Gontero group, it was similar, 30%, 0%, or complete continence, about 25% were essentially completely incontinent. We previously published on our experience here at UBC as well. This is back in 2013, 21 patients with excellent oncologic outcomes. Once again, we see that bladder neck contracture is sort of the bane in terms of a complications perspective for this procedure. Low rates of rectal fistula or other severe grade 3 toxicities, and about a 54% rate of complete continence. So moving into ablative therapies, perhaps the longest standing sort of challenger to salvage radical prostatectomy is cryotherapy, which has likewise evolved over the years. And modern cryotherapy involves 2 cycles of rapid freezing to a minus 40 degrees Celsius and passive thawing, with advancements of argon cooling, which allows for smaller probes, truss guidance and monitoring of the ice ball, as well as urethral warming to decrease the complications. In terms of the other, or when compared to the other salvage treatments, more robust oncologic outcomes follow up, which is relatively comparable to salvage prostatectomy, although I would say on the lower side, just from this cursory look. Incontinence, slightly lower than salvage or radical prostatectomy, lower rates of stricture and bladder neck obstruction. The most feared complications historically with this procedure were fistulas and rectal injuries, which seem to have declined in more modern series. Once again, erectile dysfunction is high. The other ablative therapy, which is more novel, it's been around for a while, but only approved by the FDA in 2015 is HIFU, which uses coagulative necrosis, internal cavitation. There's not as much robust data on HIFU, really predominantly reporting just on biochemical recurrence, and notably higher complications in function and poor functional outcomes. Very limited long-term data. So sort of surprisingly, I think, at least to surgeons, brachytherapy and external beam radiation, so basically reirradiation, or certainly salvage options post-radiation as well. These are two trials. They're the only prospective trials looking at brachytherapy, but they have quite a nice long follow-up in the Smith trial, average follow-up of 6.3 years, with about a 13 to 16% grade 3 toxicity profile. And what is interesting, that it kind of plateaus off rather than continues to increase, which is what I think we often see with radiation toxicities. And once again, comparable oncologic outcomes. And studies of comparing the low dose rate versus high dose rate have been relatively similar. The other option is, of course, stereotactic radiation. Again, this is something that is more recently being considered, and once again, limited smaller studies with shorter follow-up. These are respectively the largest and longest follow-up series looking at SABR for post-radiation recurrences. They're both still quite small. They predominantly looked at patients who had external beam initially, and there was some evidence that patients who had brachy had a high risk of complications when salvaged with SABR. And once again, no longer term oncologic outcomes really reported in these series, predominantly just biochemical recurrence following salvage. And of note, these are grade 2 toxicities that were reported here. So seemingly low salvage, or so low toxicity rates. So with both brachy and SABR, the concern is around risk to normal tissue toxicity. It's relying on a high degree of dose delivery, accuracy, and precision. It's often used, the SABR is done with a cyber knife. And it's not accessible to all patients. So if you had significant grade 2 plus toxicities from your initial radiation, it would not be recommended. Likewise, the same criteria regarding prostate volume apply for salvage brachy as well. So there's been some interest in comparing these salvage modalities to the degree that's possible. But in general, all of these modalities suffer from a low level evidence. They're essentially all single arm retrospective cohorts. Many of them are small, many of them have short follow-up. And Comparison is further limited by different treatment eras between different modalities, particularly when you look at salvage radical prostatectomy. It's challenging to look at a treatment that spans, at this point, 40 years. Comparisons, or many of these studies had very heterogeneous study populations and also heterogeneous outcome definitions, particularly when it comes to toxicities. There was a recent systematic review comparing all of these modalities, which is actually what piqued my interest in this topic, which suggests comparable oncologic outcomes across the modalities, except really HIFU was a little bit lower. And it suggests that reirradiation actually was resulting in the lowest severe toxicities. But again, this is considered weak evidence and subject to all of the above limitations. So here's a summary of the results of that study. So in conclusion, there's evidence of undertreatment of local recurrence following primary radiation. I think it's driven by the challenge of confirming, or at least the historic challenge of confirming isolated local recurrence, as well as the reservations due to morbidity from salvage options. PSMA-PET is really driving a paradigm shift in this context in terms of staging. We do also have improved understanding of disease biology, facilitating better selection of patients with the highest risk of progression who might benefit from more aggressive salvage. But the optimal modality in general does not remain clearly established. As we saw, that there's a suggestion that salvage radiation is lower toxicity profile. But this is based on limited radiation or limited evidence. And we also have to consider the fact that salvage prostatectomy has also dramatically changed over the years. So is there a standard of care for patients with biochemical recurrence? I think it remains still highly individualized, taking into account the patient's risk group and to current PSA level, their age and comorbidities, their current toxicities from their initial treatment, as well as the potential toxicities from the proposed treatments, as well as down the road incorporating PSMA-PET. I want to thank Dr. Gleave for providing me some insight and guidance regarding this topic.